My name is Sharon Kleinheim. I'm from Clinical Education. I am the facilitator for Nursing Grand Rounds. We have a presentation. Can everyone hear me first in the back? Everybody's good. Okay. So we have a presentation for you today on massive blood transfusion. It's going to be delivered by Sue Durdu, who is the nurse practitioner for Women's Services. If you've got any pagers, ASCOM phones, anything like that, if you could please put that on mute. And then when you return to your unit, we are going to present this again at 12:45 to 1:15. So any of your coworkers that can make lunch at that time, I will be actually showing the presentation because we're recording it right now, and then it'll be on HealthStream in 2 weeks for those who are unable to attend today. Okay, I'd like to introduce Sue Durdu.
Hello, Karen. How are you? Wow, what a great crowd. And that is just so exciting, which just tells me there's a lot of people who maybe don't feel as secure as they could around massive transfusion. And I would love to say that we're going to cross all those T's and dot all those I's for you today. But truly, in a 20-minute time period, I can give you a really good overview and let you know that we're working towards our protocols for massive transfusion. And so you're going to have more to come as we go further in our own institution in putting those protocols together. But the reason that these, well, let me talk about objectives first, and then we'll go through that. So we're going to look at a little bit of the historic perspectives of blood transfusion and talk about what we've learned about how blood is transfused from things that we've learned on the battlefield, and talk about their influence in our current protocols and how we're putting those protocols together. I'm also going to give you some examples from people who have done a really good job and show some of the things that are already in place. And then we're also going to talk about how guidelines can be used in our own institution. So anybody here been a part of a postpartum hemorrhage? Just because that's my world, and doesn't stay in my world. I know that crosses lines over into interventional radiology, into our step-down units, into our intensive care units, and it's a pretty frightening thing, yeah? Okay, so let's talk about it a little bit. So we're going to talk about a few good definitions, and because it's things learned on the battlefield, we can't help but have our own little MASH kernel here helping us out. And so you can see that we don't even have a true definition of massive transfusion because there are so many. And you can see that we've got one that says transfusion of 10 units of red blood cells in a 24-hour period of time in response to massive uncontrolled hemorrhage. And then we continue on with transfusion of 5 units over 3 hours, 60% of blood volume within 3 hours, 20 units of erythrocytes, 4 units of blood within an hour. So we don't even have a lot of agreement on a true definition. And then the one down here at the bottom, that's the CMQCC, and that's Women's World because they have given OB their own definition of a massive hemorrhage and transfusion, which is greater than 4 units of packed red blood cells. So where did we learn all of this? Blood transfusion came of age in the 2 world wars. That was a long time ago. And yet there was not a lot in the intervening 70 years about how to make it better, what we could know that would make it better. And so that has just started to get a lot of attention and see some change. And you can see that the old practice was if 1 unit of blood cells is good, 3 must be better. And a lot of times we transfused a lot of units that were unnecessary or we didn't have a lot of thought behind them and certainly didn't have a lot of evidence behind the practice. But what were the problems? And again, we're looking at the 70 years between the world wars and now, and limited ability for procurement, especially out on the battlefield, problems with storage of blood, the safety issues that went along with that because they didn't have a lot of means of identifying what was good blood, what was contaminated blood, and then again transfusion of massive amounts of erythrocytes without regard for the importance of the other products. So in the current day, what's changed? has the battle wounds changed? You look at World War I, World War II, and you look at now, what's the difference between our wounds, our casualties? Throw it out there for me. Are they better? Are they worse? They're coming back very maimed. They're losing body parts. They're losing arms. They're losing legs and things along that line. And they found that with the massive blood needed for these casualties, there were a lot of effects from just continuing to give the red blood cells. So people then, once they started changing their practices, we had a lot more people that could come home. And so we're going to talk about how we're going to apply those practices into our everyday experience now in St. Joseph Hospital. Okay, so what did we learn out there? We learned that when large amounts of blood and blood products have been used in a reactive way, because usually we've been reactive. They keep losing blood, so we keep throwing blood up. We aren't being very proactive. Does that make sense? Okay. That the outcomes are very poor, and our ability to overcome the coagulopathy was very poor and very inhibited. So what did they learn? They learned that early aggressive use of blood components, not just packed red blood cells, all the components that go along with it, improves our outcomes. So what do we have to know? We have to know about our 4 hippos. It's actually hypos, but I thought it was cute, so I thought maybe it would wake you up a little bit. So our 4 hypos that we have to think about when we're looking at massive transfusion is our hypothermia, hypoxia, hypovolemia, and hypocoagulability. When we look at those 4 hypos, you can see the Venn diagram. None of them can be treated separately. All of them are very interrelated. All of them are very dependent on each other, and all need to be addressed, all need to be corrected in order to get a good outcome for our patients. So we're going to talk about each of them a little bit independently, and we're going to see as we go through the slides how they relate to each other. And of course, hypovolemia is going to be a major challenge, especially if it is a patient who is continuing to bleed and we're trying to get on top of the process there. So certainly we're going to correct the deficit of blood volume with the crystalloids, so getting our IV therapy on board, and volume expanders to help out with the hemodynamic changes there. And here's the goal, is that we need to stop the bleeding rather than replace the blood loss. And a lot of times we put that cart before the horse. We've just been trying to replace the volume and limited ability to replace to stop the bleeding. And then these are just little FYIs. The loss of 150 milliliters of blood per minute results in the loss of half of the blood volume in 20 minutes. That's not a lot of time. But as women, we do it better, we do it quicker. In our world, a woman can exsanguinate in 8 minutes. We are women. Fear is roar, right? And that's a really frightening thing. And again, let me see that show of hands of everybody that's been involved in a postpartum hemorrhage. Okay. Frightening? Yeah. Yes, because in 8 minutes we can see some serious, oh my God moments. Yes? Okay, hypothermia. And this is sometimes something that we forget about, is the hypothermia, is that our patient's their core temperature starts to decrease. And what does that do to the patient? It really causes a lot of changes. First of all, we can see that the erythrocytes are stored at a very low temperature. And when that happens, when we start putting our blood in rapidly, 6 units of RBCs are going to decrease the body temperature by 1 degree centigrade. 10 units of cold blood products and an hour of surgery can lead to a 3 degree centigrade decrease, which is really significant. But more significant, what do we need to know about that significance is that it causes the release of intracellular potassium and increases the affinity of hemoglobin for oxygen. What does that mean to us? It means that we think that we're putting in the ability to oxygenate that body real well, and we're helping, but it's not the same RBCs that we have in our own body that are going to give the same degree of oxygenation. Does that make sense? And that's as a result of the potassium release there. And then it also results in the decreased production of clotting factors. So now we aren't providing as much oxygen as we think we're providing, and the clotting factors are decreased, so we're actually enabling the continuation of that bleeding process. Make sense? Yeah. You're busy. Okay. And then also decreases the hepatic clearance of citrate, which is a preservative in the blood products. And so when they're cold, the ability to bring that pH level back to normal decreases. And we know that acidotic blood doesn't create as much of an ability to oxygenate. Yes? Okay. Now, the hypoxia. In addition to the decrease in the circulating red blood cells, because obviously if we're bleeding, we're losing a lot more of our red blood cells, the hypothermia, hypoxemia, okay, yes, we're there. Hypothermia creates the release of that cellular potassium. So again, we talked about this one already. The oxygen is less available to the cells. And then the oxygen released by the transfusion of stored red blood cells are decreased with comparison to the host red blood cells. And then this stored blood has a decrease in the 2,3-diphosphoglycerate DPG levels and has saturation of the values that affect the blood's ability to transport oxygen to the cells. So it's kind of a triple whammy there. Hypocoagulopathy. There's a dilute effect from the infusion of the crystalloid volume expanders. Not a surprise there, because we're putting what used to be blood, we're now putting IV fluids into. So it is dilute. And then the acidosis interferes with the assembly of the coagulation factors. And then as the pH decreases, the ability to coagulate decreases. So as we continue to build up acid levels in the blood, our ability to coagulate decreases. And this is a biggie. The hypothermia reduces the activity of the coagulation proteins and prevents the activation of the platelets. And I know in our world that's not sometimes the first thing we think about is our bear huggers and such, and so as a direct result, we are really chasing our tails because the platelets can't activate and the coagulation ability decreases, and that's what we are desiring, is this patient to be able to coagulate a little bit. Okay, so for each 10 to 12 units of packed red blood cells, there's a 50% fall in the platelets. So that's pretty significant, yes? All right, and we've got our own preservation and storage issues. So we've got complications that can be caused by the preservation process of blood, whether it be adverse reactions to the transfusion. And in this time frame, we don't have the time to talk about adverse reactions, so we're not going to do that because I want to talk more about policies and protocols. But we know that the stored blood has increased acidity, and we've already talked about the effect of that increased acidity on oxygenation levels and coagulation levels, yes? All right. Elevated plasma potassium, again, we've discussed that already. The decrease in the DPG levels, and the platelet function decreases with storage, and levels of factor 5 and 7 decline in the plasma. So if we can stop the bleeding more, use less of the blood, our patients are going to do better. You with me so far on that? I got one shake of the head. That means we are all in agreement. Okay, and this was a staggering statistic to me, so I threw it up there on the board for us all to just kind of ruminate over. Now, I'm not sure how they do the math here, because I figured if they got 25 units, they were exposed to about 25 donors. But in this particular literature review, they said that it's an average of 25 units, 80 different donors, which when you think about that, that is just mind-boggling. And so then, again, infusion of massive quantities of blood is a risk factor for organ failure. And we still do have the ability to transmit infectious disease as well. So when and how to transfuse, there's a lot of literature that gives us a lot of information. The things that they could agree on were you want to avoid the 6 milligrams per deciliter of hemoglobin. And in the advanced trauma life support, they called for a 1-to-1-to-1 ratio of RBCs, fresh frozen plasma, and platelets, and then the California Maternal Quality Care Collaborative, CMQCC, that's where we go with that, recommends a 4 to 4 to 2 ratio. Now, the one thing that they also agree on is if you're giving 3 units of blood, we need to use a blood warmer to warm the patient, and then to review the coagulation parameters and metabolic status regularly, and the suggestion was after 4 units of blood and after 10 units of blood, just to make sure we're staying up on top of those as well. And then what we know that transfusion of red cells improves and maintains the tissue oxygenation, and then as an FYI, each unit of packed red blood cells contains 200 milliliters of red cells and will raise the hematocrit by 3 to 4% points unless there's continued bleeding. In my world, there's almost always continued bleeding, so that's going to be an estimation. So, when you are having that kind of day, and you can see that this young lady seems to be very upset, and she says, oh my God, we have a hemorrhage in labor and delivery. Does somebody have a plan? What happens when we don't have a plan? We have failed communication. SBAR, who's going to do it, when are they going to do it, how are they going to do it? We have noise, we have chaos, we have errors, we have lack of standardization, we have duplication of responsibilities versus missed tasks, and we have gaps in the surveillance of other patients. If I've got a hemorrhage in 14, the patient in 15 and 16 and 17 still need care, but I need people. And so how do we balance that? Other costs, patient and family satisfaction. I can't tell you how many times I've gone into a room after a situation like this, and the family's perception is they just didn't know what they were doing. Nobody knew what they were doing. Now, we all knew what we were doing. We were all stumbling over each other to do it, but the family's perception is, they just didn't know what they were doing, and they find it very threatening. They question the outcome, and not a good thing. And then supplies. How many times have you gone in after the chaotic experience, and there's 700 gloves out, and there's 3 Foley trays, and there's packages open, and there's just a lot of waste when it comes to our supplies as well. Cindy and I were talking about a young lady who was hemorrhaging, and somebody said, I need a Foley, and 3 nurses left the room to get the Foley, and they all went to different places to get the Foley, so they didn't run into each other, and they didn't know that 3 people were getting the Foley, and then they came in with the packages open, and we had 3 Foleys. So how do we prevent this? Has anybody experienced this? Okay. Or this. Okay, we've got a hemorrhage in labor and delivery. To get this, where you can see, and it's not the best of pictures, but you can see that there is a person in charge. Everybody's paying attention. We've got a game plan, and we're going to take care of business. So this is where our protocols come into play. Let's build a protocol. The must-haves. This is a busy screen. I don't expect you to read it, so I'm just going to kind of go through the must-haves very quickly. It must be interdisciplinary, because I can make all the protocols I want, but if Ms. Diane's blood bank doesn't understand what I want, we're not going to work very well together, and we're not going to get a cohesive game plan together, and it's not going to work. I need my doctors on board. I need a team. We need a process for recognizing and responding. We need written criteria to recognize early warning, the ability to improve communication, the ability to rapidly deploy people and supplies, the ability to expedite delivery of blood components, a standardized ratio of blood components that is in accordance with the literature, and order stats. So, there's a lot of people who have done this work for us. Let's not reinvent that wheel. Let's just perfect the one we've got. Kind of looks like my car from time to time. Now, this is a busy one that I don't expect you to read, but this is my go-to place. This is the CMQCC, and the things that I'll point out on this is it tells me who I want, If this is my patient, I want to activate the protocol. I want to notify my obstetrician. I want to notify the charge nurse, and I want to notify anesthesiologist. And then I want to IV, I want to do fundal massage, I want to give my medications, which are Methergen, I want to get my oxygen on and see what my stats are. So it tells me step by step by step by step what I want to do, including keep the patient warm, which would probably not be first on my brain. So always having checklists are one of the best things we can do. Crew training will teach you that as well. Having those checklists are very, very helpful. And then it also tells me what I need to be thinking about. Uteroanatomy, laceration, placental issues, and all of those things. And this does go through, this is a stage 1 hemorrhage. And they actually take us through 3 stages. By the time you're in stage 3, it's the circling the drain stage, which is not a good place to be. And it tells everybody who needs to be doing what my anesthesiologist needs to be doing, what my obstetrician needs to be doing, very, very clearly identified roles. And as I go through, you're going to see other places what they've done. This is Hope's ability to take blood to us very, very quickly. And you can see that it has room for everything. Now we've got our own card here. I just didn't have a pretty picture of it, so we're showing Hope's because they had a pretty picture of it. And that gives the ability to bring it to the bedside. If the patient moves, it comes with us. So an order set. And we are building our order sets. And I know in Hope we've done extensive work on this, and I know in the rest of the hospital there's some work being done as well. It's obviously in the blood bank's best interest if we all work together and kind of get a clear guideline for that. And this again is Hope's, and you can see that they have waves. On the first wave, this is what comes. Whoops, back it up. 6 red cells in a cooler, and they have a rapid transfuser or infuser that we don't have here. We've got then the next wave is platelets and cryo, and then wave 3, 6, 6, and then wave 4, 6, 6, 1, and then they just alternate between wave 5 and 6 once they get there. Now, pre-planning. Communication, if that's going to be an issue, pre-planning is going to be your best bet. Who notifies? Who gets notified? Who responds? When they get there, what are their responsibilities? Who's going to be the SBAR person? Who's going to mind the fort? Who's going to take care of those other patients? And escalation process, you always have to have a review process. When you're all done, how did we do? What did we do well? What do we need to do better? And who's going to talk to the family? And again, that all happens in the pre-planning stage. That pre-planning tells us how many participants, or limits them so we know who should be there. It identifies who should be there, and it defines their responsibilities. We're going to look at Kaiser's model, which I think is a really good model, and they have zones. And you can see, no man is an island. They each have their own zone, but they do overlap. And this would be something that would work in my world, certainly not in everybody's world, but you can see they've got the nurse 1 is over here, nurse 2 is over here, nurse 3 is over here. These 2 overlap at the baby, and these 2 overlap with anesthesia so that the excellent care of the patient is being taken. And I'm not going to have you read through all of this, but you can see that they have clearly identified roles for nurse 1. They have clearly identified roles of nurse 2 and nurse 3. And they also have identified what Dr. 1 should be doing, what Dr. 2 should be doing, what anesthesia should be doing. So very, very well thought out process. And the benefit, decreasing the chaos, decreasing the waste in supplies, decrease in exposure to infectious agents, improves communication, improves support of the patient, and surveillance of other patients, and a positive patient perception. Concise, accurately timed SBARs. So what is our job? We are the experts. We are the ones at the bedside. We are the ones that develop and implement the transfusion protocols. We identify the patients at risk. We are the ones that are responsible for the communication because we do it better than anybody else on the planet. coordination of procedures with attention to the hospital policy, administration of blood products because it needs to be precise, it needs to be accurate, the right patient getting the right blood, monitoring the vital signs and the effectiveness of the blood components, prompt intervention when the abnormal findings come up, and this is our strength, is staying one step ahead and always anticipating, because that's what we do. So our key points: blood is a limited resource that has the capacity to save lives, but treating a patient with massive transfusion is complex and challenging for even the most experienced staff. And outcomes improve when we understand the physiology of massive blood transfusion. We use a systematic means of delivering massive amounts of blood that includes early identification, early and aggressive use of blood components, checklists, and this piece right here cannot be overemphasized, drills and repetition. Getting people in, being nurse 1, being nurse 2, and really solidifying in your mind, because if I walked in and they said, you're nurse 1, I'd go, yeah, unless I had drilled it, I looked at the checklist and I understood what that meant. So, when we get all of that in line, we give the best care anywhere. Questions? How's that for talking fast? Like a, yes, ma'am.
What was the protocol? Is 4.2, that's 4 packs of replication platelets?
Correct. Yes, ma'am. Oh, the question was the CMQCC, what does that ratio mean? And it was 4:4:2, which is 4 of the red blood cells, 4 of the plasma, and then 2 of the platelets. Any other questions? Class dismissed. Your time is valuable. Thank you for coming.